I will. Okay. So thanks to all for coming back. We're going to have some fun here. We have two panels coming up. So the title of this session is Exploring New CT Imaging and Artificial Intelligence Technical Opportunities. We're going to start with a panel focused mainly on photon counting CT and also artificial intelligence, primarily around what are the new opportunities for doing CT reconstruction with artificial intelligence. So there's going to be a lot to discuss there. In addition, we're going to be also going over a second panel looking about how AI integrates into the clinical workflow. It's a little bit more involved. There's a lot of opportunities there that haven't really been discussed in other forums. I think we're going to get into some really interesting opportunities there as well. So I'm just going to give a quick intro to the whole session. These are my disclosures. I should go full screen, right? Yeah, there we go. Oh, and there's the panelists. All right. Thank you, guys. Okay, so yeah, these are my disclosures. And I just want to point out that it's really been an amazing journey for CT. Last year, we celebrated 50 years of CT technology being on this planet. And one of the first images of a head is on the left there. I believe that took around 5 minutes to acquire that data. I don't know what the dose was, but it probably wasn't low. And the number of pixels that you see on that image, you can actually count them with your eye. To the right is a more modern CT image of a head. Of course, now we can do spectral imaging. Now we have great coverage. The slice wars, which took place pretty much from 2000 to I think it was 2009, 2010, brought us from like 1 or 2 slices to per detector to I think it was we hit around 256 10 years later. So we had great coverage. 1 rotation around the patient, we could get something like 30 centimeters or 25 centimeters of coverage. And the dose reductions have been just absolutely amazing. But today we're going to talk about photon counting CT, and there's really 3 big things coming with this that I'm aware of, and our panelists will chime in. I'm sure we're going to talk about a lot of these issues. First of all, the in-plane resolution from the latest photon counting CT, from the one that's been available for last year, FDA cleared for the last year from Siemens, is claiming a resolution of 0.2 millimeters, which is quite a big dramatic jump from where we are now. Most of our CT scanners out there today are operating more like 0.4, actually, or 0.5 millimeters. So we're talking a major shift in in-plane resolution. Having done work many years ago on some prototype scanners back at GE, I know that if you get down low enough, you can start to see the septa between alveoli, I think it is, and lots of other really interesting things. So a whole bunch of features in every field. If we can get better resolution, significantly better, many discoveries are made, and lots of advances are made if you can do that. But if you get better resolution and you don't have much higher detector efficiency, you're going to get a lot of noise. And so we're expecting, and we've been hearing about, better detector efficiency, especially with respect to the algorithms, the reconstruction algorithms, and then finally, energy resolution. Now, Mario Silva is with us. And Mario has a framing presentation he's going to give. So I'm not going to go into the details of this, but it is very, very exciting. And we also have Jim O'Doherty from Siemens, who's going to give a talk directly from the main manufacturer that's out there providing photon counting CT systems right now in the field. So very exciting area. We're going to get into that. The other area we're going to spend some time on is deep learning AI impacting CT reconstruction. Now, to be honest, I've been in AI since 1987, and this scares me a little. It's also a great opportunity. So because we want to be very, very clear how these images change, not just that they look pretty, but that they actually are quantitatively better than the images we had before, down to scales that most people don't really care about, but we do because we're working with small lung nodules and many other things that are at a very small scale. So again, Mario's going to walk us through Mario's going to walk us through the photon counting, and then we're going to have our panelists weigh in on CT reconstruction. We have the benefit of having Raul San Jose Estepar from Brigham and Women's Hospital with us, Sean Fain from University of Iowa, and Tim, I'll just say Stick, because everybody does, from University of Wisconsin-Madison. And I just want to end with a kind of an interesting thing that's also going on around CT image formation. There was a recent LinkedIn post that caught my attention, might have caught yours, about a group that's got an FDA cleared device to take an MR scan and produce a CT scan from the MR scan. And primarily they're looking at creating a bone image. And that's a very interesting use of AI. But again, we're talking fundamentally different physics, fundamentally different signal. There'll be lots of cases where this will probably not work really well, but maybe in some application areas it will. And this is what's going to happen with AI. As AI rolls out into the medical world, we're going to get lots and lots of applications, and a number of them are going to be a little scary, actually, because but I think one of the recommendations we're going to talk about coming out of yesterday's technical breakout, which I'll give a preview of here, is we got to do a lot of validation of these things as they come out, because there's just a lot of potential here, not just for great things, but also for some shocking things that we might not like. So with that, what I'd like, I just want to point out one of our great collaborators out there, Chuck Hatt, wrote in response to this, someone's going to get really hurt by this. You can't fool physics forever. So I'm closer to where Chuck Hatt is on this, but it is an interesting discussion going on right now in the field regarding how AI is being used in medical imaging. So with that, what I'd like to do is turn it over to Mario Silva, who's going to give us an overview of CT photon counting.
Hello, everyone, and thanks for the invitation to this quantitative imaging workshop, 19th edition. I'd like to thank Ray Avila for invitation and all the board, including also Jim Mulshan and other people. So my name is Mario Silva. I'm a radiologist based in Italy, and I'll be here talking about this exciting new topic. It's new CT technologies with new opportunities. Thing here is that we are going to have a new definition of CT imaging in the next years, actually already on the ground since a couple of years or so. So these are my disclosures. So the thing here is that we're moving from a type of detection of the energy, which is the old energy integrated detector, which used to detect the photons, the X-rays, directly on a detector. But this was limited because some of this information was lost, and of course, and most of all, the granularity within this information was not achievable. We're now moving to a new type of detector, which is called photon counting detector. And basically, this new kind of detector is able to take all the information from the X-rays and to modulate it into different energies coming to the detector itself. So there is a advantage in the energy, which is because this includes all the photons up over a certain threshold. Below that threshold, everything is considered to be noise, actually. So we get more energy at our detectors, but also we get sub-pixel imaging, so we get to a better resolution of the image. So more energy detected with less noise and more detail. This is very important to remember. And this is also very important because with this new detectors, we can have a good efficiency of the image quality throughout the energy levels, which is opposed to the energy integrated detectors that had increasing responsivity of the detector as the energy increased. So with this technical concepts in mind, we can say that we have now a improved ability to detect the signal, and this improved ability translates in abutting the noise and in being able to evaluate the energy that each photon is putting into the subvoxel detector. And as the quite complicated mechanism of a photon counting detector is based on, basically we can have discrete thresholds, and here you can see the exemplified the threshold of kilo electron volt equivalent below 25, which is considered noise, and then at steps of about 25 kilo electron volt. And for along these 4 steps, you can recognize 4 different chromatic features of the energy that is assumed there. What does this thing means? So better efficiency of the detector, less noise. Whatever is below this threshold of 25 is not detected, and this is very good for quantitative imaging, excellent for quantitative imaging. This also reflects in less streak artifacts and more stable CT numbers, therefore. So we have a first achievement with better image quality, with lower image noise, even at lower dose. And this is very important. But on the top of that, we're getting also simultaneous readout of the CT data in different energy bins, which means a spectrally resolved measurements. So we don't just have quantitative biomarkers with density anymore, but we have spectrally resolved measurements all over for any acquisition that we do with this kind of technology. So let's see what literature already said about these things. We can use photon counting detectors for reducing the dose, as we said before, in different settings, in lung imaging, especially because the substrate, the anatomical substrate is great for that. And what the literature brings to us is that's the photon counting CT with a dedicated iterative reconstruction, quantitative reconstruction, quantitative iterative reconstruction dedicated for photon counting images gives you a much better image quality at lower dose, as you can see in this example from the paper from Voltaire et al., published in Diagnostics this year. Another example from the literature comes from investigative radiology. And this is actually already in press. And if we can move a bit further from the quantitative evaluation, we can also appreciate here how the photon counting with dedicated reconstruction also improves the visual detail of interstitial findings. And this is reflected in improved reader confidence in the diagnosis of a disease such as the usual interstitial pneumonia, where you have to have reticulation, ground glass opacities, and also mosaic pattern in some areas as it might be defined. So quantitative improvement, but also visual improvement, we're taking it all with just one new technology. And also another paper which is based upon radiation reduction and image quality maintenance, as this paper from Zurich. Actually, sorry, this is from authors from the US. Sorry for the mistake. And in this paper, they could show that a reduction of 66% of those was visible in for reading images with usual interstitial pneumonia again. And this is so important. Also, if you look at this very, very faint ground glass opacities that you can see in this 66% reduced image on the bottom right image there. Again, we move to the other possibility here, and you can see that the spectrally resolved measurement can be useful for several things. One excellent example from the literature that comes in help to us is the virtual non-contrast images that you can see here. All of us quantifying emphysema struggle with the different numbers when the contrast enhances the lung parenchyma. If we acquire contrast enhanced images with photon counting technology, we can do virtual non-contrast, we can still quantify confidently and consistently the emphysema. And you can see the difference from a arterial venous phase without virtual non-contrast, contrast enhanced, and with virtual non-contrast, which becomes more comparable to a true non-contrast image. And this paper was published in British Journal of Radiology this year again. Other examples about virtual monoenergetic and evaluation of contrast, because we want to do reconstruction in virtual monoenergetic to improve the detection of contrast in arteries. And we still want to have a good reading for the emphysema. And this is one of the most advanced paper where the monoenergetic reconstruction was compared with the virtual non-contrast to assess a good middle way between the perfect monoenergetic for emphysema, for pulmonary embolism, and the most appropriate threshold for emphysema. And here you can find that the best trade-off was seen for 60-70 kiloliters volt. So I hope I've opened some topic for the discussion for the next session. And let's enjoy the discussion with big experts from all over the world here. Thank you.
Something. All right. So what we'd like to now do is move over to our panelists. I'm sorry, to Jim O'Doherty from Siemens Healthineers. So Jim, do you want to tell us what Siemens has to say about the experience of having Somatome Alpha out there for last year?
Yeah, absolutely. I mean, we had it installed in the US. We had 3 sites first as investigational research sites, pre-FDA clearance, which happened in October, November last year. And since then, it's just kind of grown. So we've had a lot more installations around the US and with our colleagues in Europe that your previous speaker talked a lot about their research. It was approved a lot earlier in Europe. So that's kind of why most of the research out there has come from places like Zurich and Germany and Sweden. But yeah, we kind of highlight the benefits as being, like your speaker said, increased spectral resolution, spatial resolution, same energy weighting of low and high energy photons, and the fact that it's a direct digital conversion. So it's up to our clinical colleagues. I'm a physicist by background. It's up to our clinical colleagues to kind of elucidate those benefits and demonstrate its use in a clinical scenario. Okay, thanks. Thanks to the organizers for inviting me to give a talk. I'm just going to discuss some benefits on photon counting CT, technical benefits of a new type of CT technology made by Siemens, essentially, in this case. Traditional CT detectors are run on what's called energy integrating modes. So essentially what you have is a scintillator, which is a solid state scintillator, which essentially converts the X-ray photons into light. That light is then detected by some photodiodes that you see there in orange. And this is called an indirect conversion. So the energy is integrated during the measurement time of one projection, and all this energy information is lost as the signal is combined, which is what we call an energy-weighted cumulative signal. New types of technologies such as photon counting CT do not require the intermediate step of generating light. Instead, they directly convert X-rays to an electrical signal which we use to create an image. There's also an energy dependence of photon counting X-ray impacts. Low energy X-rays produce small amounts of charge, and high energy X-rays produce more charge. So the difference is that with the elimination of intermediate step of generating light, we can measure each individual X-ray and therefore their energy. This allows us to have spectral information without any dedicated scan modes or any extra technology. So there's no need for dual source, dual energy, or fast KV switching or dual layer detectors. So essentially, what I'll try to talk about very quickly is 4 technological advantages of photon counting detectors. And the first one is that the detector pixels can be much smaller. So essentially, we have on this particular scanner made by Siemens is a large pixel of 0.4 by 0.4 millimeters, which can then be subdivided down into 0.2 by 0.2 millimeters, which gives us an in-plane resolution of 44.3 line pairs per centimeter, which is really, really good. And I'll show some images about that in a little bit. The next is that we can eliminate electronic noise because we can apply a digital threshold. So essentially, we know what energy these photons are. And if they're above a certain threshold, we count them. If they're below a certain threshold, we don't count them. So that way we can eliminate electronic noise from the images. The third is that we have spectral sensitivity. So these pulses can be sorted into 1 or 4 energy bins, depending on what way we want to make the image. The detector always acquires the spectrally resolved signal, regardless of scan speed or temporal resolution. So it's a bit different from traditional dual energy. And the last is equal energy contribution. So the detector response is consistent with energy, unlike energy integrating detectors, where you do not have a consistent response with energy. So the lower energy X-rays count less in traditional EID. So with photon counting, you can see the orange line there. It's a bit more consistent in terms of the energy. A very quick case study that we found at MUSC in Charleston. This was a very large patient of 410 pounds, a BMI of 63, scanned over a period of 3 months for an ovarian mass. This is a scan from a Somatome Go Top. So you can see it's quite a poor, noisy image because of the patient's body habitus. Similar scan a few weeks later on a Somatome Force. It's better, but it's still reasonably noisy. And on the photon counting system, we actually get a reasonably good image. So we've reduced the noise. You can see the CTDI is a little bit higher as well because it was bumped up by a few percentage because of the size of the patient. But we have some artifacts there around the pelvis because of photon starvation. But essentially, it's a much more improved image. So it just kind of goes to show that the noise can be reduced. Like I said, this is the second one of equal contribution of X-rays. So with, like I said earlier, if you have your traditional energy integrating detector, there's a down weighting of those lower energy X-rays, which reduces the contrast to noise because low kV is required to boost that iodine signal. With our photon counting system, we have kind of the opposite. We have a fairly stable response with energy. So there's no down weighting of those low energy X-rays, and it uses the full spectrum of X-ray energy at an equal level. And the time for a signal measurement is much smaller, 15 nanoseconds, as opposed to 250 microseconds for the EID. This kind of translates into slightly increased tissue contrasts. You can see there from that example, and also a higher contrast to noise ratio for the same kind of scan compared to standard CT. In this case, it's improved in particular a high kVp, so either 120 or 140, which is what we tend to do most of these photon counting scans at. And of course, with this higher CNR, it allows you to potentially reduce the radiation dose or use less contrast agent as well. This is an example that predates our specific scanner that was released in 2021. So this is an example you can see on the left of energy integrating detector lung scan. And on the right is a photon counting scan. So you can see the kind of improved resolution going from left to right there in those columns. And the kind of summary of this particular paper was a high resolution photon counting detector increased the radiologist's ability to visualize higher order bronchi and bronchial walls without compromising nodule evaluation with current chest CT. Another scan, 74-year-old male, diagnosed with interstitial lung disease consistent with idiopathic nonspecific interstitial pneumonia. I'm not a physician, by the way, so this is from our clinical colleagues. And you can see the resolution here, and the query was, is there reticulation or ground glass opacity? And looking at a photon counting scan, we can see that there isn't any ground glass opacity and just reticulation. So obviously this is a marker for interstitial lung disease. And the confidence of reticulation was increased in 2 readers using photon counting CT. Another scan of post-COVID patient with photon counting CT, you can see the energy integrating standard CT on the left, reasonably okay resolution in the lung. Doing this at high resolution in the photon counting system just shows that you get better resolution. You can see it kind of tears up quite nicely. And if you add some functional information in there, you can see that particular section of the lung in terms of function is not working. We also, through our clinical collaborators, found this particular example of, sorry, go back a second, of central lobar emphysema that was only seen on photon counting detectors. You can see those 2 arrows there on the right-hand side, as opposed to the exact same location on the left-hand side, where we can't really see anything because of the level of noise in there. So we have improved contrast in there. In the cardiovascular space, we've done a lot of stent imaging. So these are ex vivo stents. So these were scanned within a water phantom, and you can see that using the photon counting system, the resolution is much more improved for the same size stent. The image on the left essentially is 2 stents, such a large stent on the left, which is about 7.5 millimeters, and a smaller one to the right of that, which is 2.5 millimeters. And you can see by varying around with the reconstruction kernel and the slice thickness, which is in brackets, the best resolution clearly is a higher kernel at the very bottom, QR72, and a thinner slice, which is 0.2 millimeters of ultra high resolution. Now that translates in the clinical space to doing the same thing. So we have a case here you can see the distal stent there at the bottom of the LAD, which on the standard resolution scan isn't really diagnostic. So it's a little bit more awkward to tell. Excuse me. It's a little bit more awkward to tell what's going on in there. For this particular patient, the stress echo was normal, so an ICA would be of no real benefit. And essentially that scan will show it as non-diagnostic and probably send the patient off for an ICA anyway. Doing that under high resolution, you can see that the stent is actually patent, and you can see things that are happening within that stent at the ultra high resolution. So this particular case with intima hyperplasia, which essentially is where the intima starts to grow through the stent and essentially potentially restenose the vessel, we can see that there's no ischemia, and then the patient would just be followed up in 1 year's time. Now, another example, looking at increased spatial resolution from our photon counting scan on the right, again, standard CT on the left, we can see that this particular patient would be graded as a CAD-RADS 3, which means they would be sent for functional testing. With our photon counting system on the right, that patient's actually graded as a CAD-RADS 2 and would require no further testing. So this shows that even at the same reconstruction kernel with a thinner slice, better resolution to visualize calcium deposits. we can change the clinical outcome using this particular system. Last one is spectral sensitivity. So that I'm sure some people know already, the principle of spectral CT is essentially to scan something at two energies, E1 and E2, and essentially look at the change of X-ray absorption between those two energies. And that's what essentially characterizes the material. So this allows you to do things like material decomposition and things like that. Now, the main output for our photon counting system is called virtual monoenergetic images. So for example, we can reconstruct an image at 70 keV, which is equivalent to doing a kVp scan at 120 kVp. So if you think about the mean of where that spectrum would be, it's around about 70, depending on the patient. You can also reconstruct images at 60 keV, 80 keV, 50 keV, 90 keV, whatever we like. Now, essentially what that does is it changes the contrast essentially in the image. So you can see at higher keVs, things look smaller, essentially for calcium deposits, and at lower energies, they look larger. So there's a bit of debate as to what the best reconstruction is, whereas before with a standard CT, there was just one. So now we have to try decide which one is actually best for physicians to use. We can also do advanced spectral processing algorithms. So this is an example again from MUSC, where we can do some calcium subtraction algorithms. So this is one example where you can see the calcium deposits here, the central image. And we can remove those using a new algorithm called pure lumen. And essentially what that does is it allows you to kind of assess the lumen itself, intermediate grade stenosis, and make a more realistic, clear assessment. Patients with advanced coronary artery disease and a high degree of calcification didn't profit from the advances of non-invasive imaging and had to undergo current gold standard catheter-based angiography. So there's a need to provide more information for these people to guide therapy and give cardiologists more space for treatment interventions, and potentially to reduce the burden for the patient to receive the right diagnosis and improve the assessment of their own individual risk. So essentially, these are the four things I'd like to kind of speak to you today. This is essentially the four things that we would like to promote about photon counting scanning: equal energy contribution, which gives us contrast-rich images; smaller detector pixels, which potentially give higher spatial resolution at the same dose. So there's no dose penalty in using UHR. Intrinsic spectral sensitivity, which gives us multispectral information in every scan. So that's a really key point. We don't need to do a dual energy acquisition anymore. It comes with every single scan. And last but not least, the elimination of electronic noise, which allows us to lower the dose. And we refer to these kind of innovations in one particular system in our Neotom Alpha photon counting CT as quantum technology. So you might see that buzzword floating around in certain places. And finally, thank you for your attention.
All right. Thank you so much, Jim. I do want to just show a little bit more of my slides for a second. So as we can see, there's really incredible technology coming. And we actually can't predict fully where it's going to go. But at the same time, we have to have a healthy dose of validation in our brain as we do this, because we've seen this before. There are times when major advances have been made in CT, like going from step and shoot to helical, and not that it affected all the scanners out there, but some of them started to do some not so great things. Like you can see here with what we found in 2010 with spatial warping. So we want to be really careful. And one of the ways we get around this is having good phantoms. And now we're using a lot more 3D printing. So you all may have seen a LinkedIn post by the Prevent Cancer Foundation showing a bunch of 3D printed nodules that we've been preparing. You can see one here. This is actually from David Yankelevitz, and you can see it's about 8 or 9 millimeters in diameter. We're packing these into canisters and we're pushing them out into phantoms around the world. I'd like to get one of these out to a Neotom Alpha Siemens scanner, photon counting scanner, so we can really see not just the fundamental image quality properties of that system in terms of its resolution, but how will it perform given the types of things that we need to measure, like a small lung nodule. These phantoms have been deployed over the last few years. And I believe now they're not quite an international standard, but the adoption is quite rapid now. And they're ultra low cost. So I expect we're going to get a lot more data around lung nodules on photon counting, on AI, CT reconstruction, and on other things. And we have now the benefit of having Raul San Jose Estepar join us. Thank you, Raul. Just in time, because you're up next, do you want to say some things?
Yes.
All right, I'll turn it over to you.
Thank you. I'm glad to be here, thanks to the fog in DC. I think the speakers introduced the topic very well. I guess from a quantitative perspective, I wanted to touch upon a few things around photon counting that I think is very exciting. So one is the resolution that I think Mario touched upon, and the fact that we will be able to basically look at the azimuth level. We are talking about 200 microns. So that is kind of a wild opportunity. That means we can see definitely early distraction. Maybe we can see neovascularization in ways, remodeling in ways we haven't been able to see before. And I think this creates sort of a new opportunity for early detection. So that is, I think to me, that is one of the critical components of this emerging technology. The other one, improved contrast. And I think my expectation, and I think the prior speakers were touching upon this around the notion that we can get now virtual monoenergetic images at lower KB. So that means better contrast. And lower KB is used nowadays in the pediatric population, and is less used in the adult because there is this balance between noise and those. But I think this new technology, my expectation, and I think that my radiology colleagues will have to set the tone or set the protocols, but my expectation is the upcoming protocols will lower the KB across the board for all the adult imaging. So that is going to imply better contrast, and therefore our quantitative biomarkers could take advantage of that. For example, emphysema scoring could benefit a lot from that to do assessment of chronic lung injury, for example. So that being said, I mean, there is a few challenges that I see, and just to wrap it up, one to me, one of the challenges of this new technology is that many of our quantitative markers had been designed a little bit to overcome current limitations of current technology. So at which level we will need to redefine those, the studies that we need to do as a community to truly either redefine them or validate them. That is indeed going to be a challenge. And thinking, for example, of emphysema scoring, some of the emphysema scoring metrics will be affected by, in a good way, but also will be affected by the fact that we have better resolution, less noise. So we'll have to redefine that. So that is something to think about. And the second thought that I think is important as a community, and I think a data-hungry community like us, that we believe in open data sources as a way to propel the field forward, is the amount of data these new devices will generate will be basically huge. I mean, it's going to be a 32-fold increase in data flow if you think about better resolution, meaning more data per scan plus the 4 energies. So how to, the logistics, the infrastructure to manage the data, even deciding what is the relevant data for the task at hand, I think that is something we will have to address as a community. So those challenges will have to be definitely addressed. So I think with that, I will let my other panelists to expand upon.
Yes. Oh, well, thank you very much. So just a thought on what you just said. I'll just throw in an editorial comment here. Up till now, we've pretty much had algorithms that ran on every output of every scanner, just about. And now we're entering an era where photon counting CT is going to produce imagery, let's say, of lung screening one day, that you need a different algorithm potentially to measure it, because you might have to undo some of the corrections that have been applied to the older algorithms. I'm sorry, the older scanners. So let's move on to Sean Fain from the University of Iowa.
Yeah, hi everyone. I had some slides that would summarize my thinking about the photon counting technology. One of the things that I would want to emphasize too is that, I'm coming at this from the point of view of an end user who is interested in quantitative imaging in the lungs and specifically making measurements of airway dimensions and geometry, as well as parenchymal density for emphysema and asthma studies that involve, usually multiple centers and longitudinal studies, so multiple scans. So dose becomes a paramount concern. I think that will also be a factor in, lung cancer screening as well. So I put together this table to kind of guide my thinking, and these are on the left. You'll see in these columns, like a lot of the innovations that were presented in the previous talks, funneling to the right in the last two columns, specifically focusing on potential impacts that I see on quantification. I do see that the benefits in terms of contrast and dose to some extent will obviously, I think, improve our ability to estimate and measure parenchymal density, and emphysema would be a major beneficiary of that area, as well as air trapping. And I think texture assessment, I think you saw some of the images that showed, ILD and texture features quite crisply with the higher resolution and the better contrast capabilities. The other thing to point out is that, we'll potentially benefit through the improved resolution in terms of accuracy and airway wall and lumen measures. But I also put in what I consider to be potential challenges, I think some of which were touched on by Raul. And these include, changes in the way in which we might make these measurements based on the improvements in the technique and the capabilities of the scanner. I think statistically based texture features may change too, because now there won't be some of these interfering factors such as beam hardening and electronic noise. And then calibrating, I think, to a new dose threshold, given the enhanced capabilities for lower dose scanning. So these are all factors I think need to be considered. I think the other factor too is that hasn't been mentioned is that if we have now a mixture of these types of photon counting systems and energy integrating detector systems out in the wild, and we're doing these kinds of multi-center studies on lung cancer screening, we now have very, very different performance, and we may want to either harmonize that performance to match performance across all of those systems, or specifically take advantage of the photon counting systems in unique ways. So I'll just stop there. I was wanting to summarize my thoughts with that table, and interested in hearing my other panelists' thoughts. Thanks.
Thank you, Sean. Next up, we have Tim Stick from the University of Wisconsin-Madison.
Yeah, thanks, Rick. You know what? Actually, my slides were talking about AI implementation. I think I created them for the next session. So I've been taking some notes here. I'm just gonna not go, we don't have to click through those slides. So I think I'm gonna start a timer for 3 minutes. And yeah, so I think the first thing that's important, I think, for us to understand in the chest with high resolution imaging is there's a fundamental relationship with speed and how much dose we're gonna get out. So we have to understand, and I think we're getting to understand that the first photon counting scanner is capable of keeping a small focal spot size and scanning fast enough. That's something to pay attention to for that scanner and any other vendors that come out. You want to scan a patient fast to not have cardiac or lung motion, you need to have a higher MA so you can get that dose out in a short amount of time. Usually that higher MA means a higher focal spot size. Who cares then how small the detector is if your focal spot size is huge? So that's something as a clinical physicist, I'm really interested in and understanding more, and that gets in the weeds quick. The second thing is we have to, remember, and Rick, like you said, these are new types of image modes and how we're going to process them and which ones we're going to use. Dual energy CT in many ways has been a complete, flop for a lot of sites. They try to implement it. They get presented with all these different maps and images. The radiologists are like, what the heck, I can see the PE on the regular image. Don't show me this iodine overlay map, so there's a huge, I think, hurdle there. That way, as a community, we're realizing we're making this problem harder because there's no new types of images we're making with photon counting. All the vendors, the commercial vendor that's out, the product, and all the other vendors in development are just trying to do regular CT and current dual energy CT images just better. I am excited about the photon counting that workflow wise, like at NYU, that's Somatom Alpha it's like, I think they have like over 8,000 patients scanned, like 40 to 60 a day. That's really awesome that it's ready for prime time. And some of the cool things I've seen at recent conferences is like it's doing better with bariatric patients and doing better with patients with their arms down. You know, that 1 in 100 patient with their arms down, and you have beam hardening and noise streak that just blows, you know, all the image quality apart. I think photon counting here could really help us there. Diameter field of view is what I'll end on. And that's, I think, just another reality in clinical situation. You know, when we do like a runoff scan, I might do a cone down reconstruction of a specific leg. So I get a really crisp image on my current scanner of today. And we do that because there's a fundamental relationship between voxel size and spatial resolution. So, you know, even with 1,000 pixels, like a 30 centimeter field of view, which isn't going to cut it for a lot of peripheral, you know, lungs, your voxel size is still like double what, you know, the scanner's detector could do. So we have to also understand some of those things. Like, are we going to do left and right side, you know, lung recons for some patients? That would be a huge change in workflow for the clinic. So yeah, I think with that, I'll stop. Thanks, Rick.
Oh, thank you, Tim. And I want to thank all the panelists. What I'd like to now do is go into some questions for the panel. And the first question I have, and I have been able to figure this out. So with Jim O'Doherty online, maybe we can figure it out real quick. We're getting great spatial resolution in plane from the photon counting system that you have. What about along Z? Does slice thickness get a lot thinner too?
Yeah, I mean the minimum slice thickness is 0.2 millimeters. That you can set with the ultra high resolution mode. There is a drawback at some points in that obviously the coverage of the detector goes down to 2 centimeters instead of the normal 6. And also the spectral capabilities at the moment can be reconstructed at 0.2 in certain modes. So you might have to sacrifice some spectral imaging for resolution. That's not in all modes. So for cardiac mode, for example, if you're doing any cardiac imaging and you do ultra high resolution, you lose the access to spectral information for that particular mode. So things are still being worked on. There's various iterations coming out that improve various things, but at the current point, the maximum spatial resolution, maximum slice thickness you can do is 0.2.
Wonderful. So Claudia, are we going to go to 0.2 millimeter slice thickness for lung screening? Just want to, especially for nodules. That would be great. Now, when we do that with Feldkamp reconstruction, you know, typically we'll get, if we cut the voxel size down in half, we'll get about 40% more noise. With detector efficiency and other things, with Jim, do we do better than, you know, an increase of 40%?
I would say so, yeah. I mean, compared to there are some ultra high resolution long papers out there from the group in Zurich. I think it was Zurich or possibly Minden. There's 1 or 2 of them at least. And they show that the noise is kind of, you know, once you go to thinner slices, it will be noisier for sure. It's whether it goes to a level of noise that you find acceptable or not. And we think that at least if you go to a 0.2 millimeter slice, the noise is still acceptable because of all the added features and bonuses of photon counting CT. So the way that we can eliminate electronic noise, all these things kind of have an added effect on the image. So we think it's probably better than 40% for sure, but that might be down to kind of local assessment and seeing what you're comfortable with in terms of
I'd like to comment a little on that. I think so. I think there's a distinction between the clinical utilization and the quantitation. So if we're interested in quantifying these measurements, I think the noise factor is an issue that needs to be addressed. I think the full resolution capabilities of the system are going to push the signal to noise ratio, even given the improvements in efficiency. So I think that we need to be mindful that the parameter space we want to use for quantitative imaging is going to have to be specialized, I think, and modified and optimized based on empirical feedback. And to access that resolution that you're seeing, for example, in the airways, you have to go to high frequency kernels and high matrix sizes, all of which amplify the noise.
Yeah, no, I'd certainly agree with that for sure. Again, it's down to local experience and seeing what sites are comfortable with pushing this thing up to.
Right. Okay. So, Jim, you had a question? Is that right?
I just want to, is there an opportunity to specialize? Special condition for looking at small cell lung cancer, which tends to be much smaller at time of clinically optimal detection. And can we work out protocols for that type of analysis?
I'm sure that we can create targeted protocols that will image that very, very much better than we can today. David?
Hello. Oh, wonderful. So I remember going back maybe 15 years ago where I was at a meeting with a lot of medical physics folks and there was a lot of GE folks, and we were talking about how CT scanning had in essence reached its limits in terms of resolution. And without major increases in radiation dose, we had kind of gone as far as we can go. Now, obviously that was incorrect. Now we're talking here 0.2 millimeters. Is it easily foreseeable for you guys that we're going to go down to 0.1, 0.05, that kind of thing with this technology? That's my first question. And my second question is, I want to get a sense as to why this matters in lung cancer screening. How much better are we going to be able to measure things? And Rick, you, I think, have the most information about this. What's that improved resolution going to do for you in terms of looking at measuring things?
Yeah, I have actually a slide. It's not part of my current slide set, but let me just pull that up.
As to the, are we just at the, scratching the surface now with the improvements in resolution? Or are we going to be very soon down to 0.1?
I've shown a slide in the past. You guys may have seen it. I'm going to share my screen for a second. I put this out a couple.
Well, Rick, while you're pulling up your slide, maybe Jim can answer from Siemens, but your guys' in-plane resolution at the would be less than 0.2, right? 0.14 or something or so.
Yeah, that's
resolution.
Correct. Yeah, well spotted. Yeah, so the actual resolution's a little bit. The in-plane resolution's a bit lower than that. Yeah.
So it's so they're pretty good. I think 15 years ago, like in the world of light photodiode, no one could imagine taking out those light reflecting septa. That was killing dose efficiency. So I think that explains why people might have said 15 years ago, like the questioner asked, why we couldn't see any gains, because we were just limited by the technology of scintillators.
Always bound by the technological landscape you're working in. So as you see these wonderful headlines about superconductors, about all kinds of other electronic advances, quantum computing, all kinds of things, these are all going to factor into the future CT scanners. I just want to point out this image that this slide that I generated a couple of years ago. We've been measuring the quality of CT scanners all over the world for the last 10 years. And one day we'll write a paper about how it's changed over a decade. But what this shows is that what we can do is we can take the image quality parameters that we get from our phantoms, and we can simulate what an image would look like if you could scan an object with that scanner, or with those scanner properties, the resolution, the sampling rate, the biases, all of the things we measure. So on the right side is the maximum of what's called the KIBA small lung nodule profile requirements. And you can see if we take an ellipsoid, you're going to get something like a misshapen potato. And many sites, when we first start working with them, they operate out to the right of that. But on the far left, I chose 0.1 millimeter as the resolution of the acquisition system. And you can see two algorithms. One is a wireframe, which is a thresholding based method. And one is a sophisticated lung nodule that's a segmentation method, which cuts off the vessels. And that's using a candy edge detector as its boundary detection method. So by the way, and you can see that the difference between the two is much closer when you're operating with 0.1. So you can actually have a not so sophisticated algorithm do okay in terms of bias on a much higher resolution image than you can if you're working with really lousy data. We are really excited to get hold of some images from the Siemens scanners and see how well our predictions come in terms of looking at the bias and the precision of lung nodule measurements. And so that's going to be exciting. I don't know if that's what you were getting at, David, but
I think one comment when we talk about resolution, one is the in-plane resolution that I think is what photon counting can push very heavily now. And then we have the out-of-plane resolution that I think Rick has done a phenomenal job teaching us that is one of the parameters that probably is less calibrated or that we want it to be. So I want to bring this up because I think in the out-of-plane resolution, photon counting still will be limited by either how many detectors you have, or if you are moving the table. I believe there is sort of a mechanical sort of issue there, no? Like the account of precision you need in how you move the gantry and so on could be a barrier. So maybe what I'm trying to say, and I want to see what the other panelists think about this, that if we want to truly move into this ultra high resolution domain for both in plane and out of plane, what we also need is go into 320, even higher, so we can get basically the full chest in one rotation and be done. So no mechanics involved, because every time the gantry moves, I think that is challenging. And I think some of the issues you saw were around those lines. So I don't know if everybody else agree or we have a disagreement, but to me, it's one of the things we might need also to move the field
what's
forward.
the coverage of the Neotome Alpha?
Sorry, you mean the detector size? 6 centimeters?
Yes. How many centimeters are we?
6.
6 centimeters?
Yeah.
So we need about 5 rotations to get a lung. Is that right?
Give or take, yeah.
Something like that. The bigger the coverage, the quicker we can get the whole lung. We have our we passed our 2-minute warning. We have 1 minute now. I want to point out that one of the things that Jim said, which is really important, is this artifact reduction. So a lot of lung nodules tend to show up right next to a rib, and there's a shadow that occurs in many cases, which will attenuate the Hansfeld units downward. And what we don't know is, how much better we'll be able to measure those nodules. But based on the theory described here, there is potential for a nice improvement in those types of cases. So there's a lot here we're going to have to get our hands around. I guess I'll leave it open. One more. Anybody want to make a final thing that they feel is really important to get on the record here?
I just would say that the expanded parameter set that is needed to be optimized for this kind of technology is a little bit daunting, and it's going to take a lot of effort from the community to come up with optimized protocols for various applications, such as lung nodule detection.
I agree. And then I'd like to close with thanking everybody. This is a very exciting time in CT imaging, and we're really looking forward to the next couple of years when we get some good data in our hands. So thank you all. We're going to move on now to the next panel. Thank you. All right. Thank you all for returning back after lunch. We're going to have a little fun for this closing session here. We're going to have more fun. How's that? So we're gonna get our arms around this issue of AI. There's lots of really interesting things happening in AI at the moment, and it seems to be accelerating, by the way. So as I said, we're going to have some fun around AI, and let's share my slides. Okay, so those are my disclosures. And first thing I want to talk about a little bit is generative AI. You've probably all seen just amazing pictures of what happens when you take a trained AI, you re-architect it, and you run it backwards. So in other words, instead of asking it what is in this image, you say, I'm going to give you some words, and you tell me what it would look like if I had a picture of it. So what you're looking at is one of the more impressive pictures from the web that they asked, what would a cat look like in armor? And you know, when you look at this, you say, my Lord, you know, what is this representation that the AI system has is quite amazing to be able to produce something like that. But we can't fully be fooled, by the way, because mistakes happen, and you should never think that this is a highly intelligent system. It has lots and lots of pattern recognition and lots and lots of capabilities. Some people call it similar to a really fast and capable pigeon, in that it can see a pattern and it can, but it doesn't have intelligence way beyond that. So in generative AI, some people have recently posted, you may have seen this, it's very funny. What would salmon look like swimming down a river? and aside from the humor here, it's getting to something else, and that is that the actual AI doesn't have a context. It doesn't have a real sense of what you're really asking. It's matching a pattern. And while this is funny in the world of cats, dogs, salmons, and rivers, we're going to be exploring eventually AI uses like we mentioned in the last session, where we're going to be generating images, and it won't show you a salmon, hopefully, in an image, but it might show you a completely wrong representation of something, and it might lead to something bad. So what we have to do is realize that a lot of what we're seeing out in the world, a lot of the applications are not mission critical, and we're dealing with life and death here. And I'll just point out this we've all been watching the Tesla assisted driving or automated driving. I forget what they call it. What's that? Autonomous driving. And I just want to point out, I've been working in AI for 35 years, since '87, really. And one thing I've noticed is that we like to give the statistic that the AI performs better than the radiologist or performs better than the driver. But the problem is that buried down in that statistic are of just a few cases that are so horrific of a car. I'm just giving you a hypothetical example. A car driving off a cliff. A human would not do that, but an AI might do that. And the problem we have, especially in lung cancer, is that we can, and I say this from experience, having put AI systems around the world in the past, is that we can get some really horrific failures. And that, as I'll summarize later, is the Achilles heel of AI. So just like all the other amazing things that are coming down, photon counting and other things, we have to be extremely careful that we use them in the right ways, that even if they make a horrific failure, there's a fail-safe that we're able to prevent some horrible thing from happening. And we have to accept that AI is going to do wonderful things. It's going to help us in lots of ways, but it's going to make some bad mistakes every now and then. And it might be rare, but for the person whose care is involved, it's really important that that we have ways of catching it before it becomes serious. So I just want to walk back in time a little bit. This is a really nice graph showing the use, actually the total number of publications on PubMed that mention deep learning, machine learning and deep learning. And you know, you can't miss the graph here. The exponential growth here is quite dramatic. Well, I haven't fitted an exponent to it, but I suspect it would fit. So I was leading GE's AI way at before this graph, back in actually 2000 to 2005. Oh wait, before we do that, notice that radiology is the second biggest bubble on here, and then oncology is the fifth largest bubble. So no surprise to us, right, that AI is coming and is getting lots and lots of attention. But I'll just remind you again, back when I was leading AI for GE, around the year 2000, 2001, 2002, we had developed an AI that would detect part solid, non-solid, and solid lung nodules, and we were not getting as high an AUC as is available today, but we were getting respectable performance, and we could detect things in very, very complex situations like this atelectasis. But back then we were mainly concerned with how do we notify the radiologist with a marker. So let's put a marker on the image as a second reader, and let's see if we can mainly improve their sensitivity and specificity, more of the sensitivity. You know, even back then, 20 years ago, we were getting encouraging results. And there were I thought, plenty of papers and activity. All the major vendors had the tools available. So let's fast forward to today. I think you may have all heard that we've been working really hard with the LCAP group and the VA to take the LCAP management system and put it inside the VA. And we call that VA PALS LCAP. It was funded by the Bristol Myers Squibb Foundation. We have that running at the Phoenix VA Medical Center, and we've got that at the Nashville VA Medical Center. The system, through the benefit of LCAP after 25 years of learning, basically covers the spectrum, the pipeline of a nurse navigator working with a participant, a screening participant, walking them through. The idea is never to lose anybody to follow up or other things. We focus also on the image quality. We've discussed that many times at this workshop. Garbage in is garbage out. So we spend a lot of time making sure the image quality, the scanner, the technician are doing really well. But then we get to the radiologist, and the radiologist has to fill out a form, and that form has lots of questions on it, like, what did a nodule grid. Fill out this nodule grid, and you will, if you fill everything out, you will be able to press a button and get an automated report, and that'll be sent to the EHR. So we actually have that all running. But then, curiously, interestingly, one of the major AI companies said to us, "Hey, we'd like to fill out your form with our AI." And we said, "Well, we'd like to create an open architecture, an open AI API, application programming interface, so that any group with an AI could fill out this form." And what we got to, we demonstrated this last year, we got to about 90% of this form could be filled out with automation and AI. And the exciting thing about that apart from, again, remember the sensitivity and specificity, we hope we can improve that. But the productivity, if we can automatically fill out forms, have the radiologist just check them over, and then generate a report that goes into the EHR. Well, first of all, we collect, this is not the system will store all the data. So we're not just left with a piece of text. We have all the pieces of information on each nodule in quite a large amount of detail. And the AI now has the potential to greatly improve the productivity of the radiologist. Now, of course, we have to have the AI perform at a certain level. It can't be a really lousy AI. Otherwise, the radiologist has to go correcting that AI all the time. So what it looks like is this. This is on the left is the CT eval form. And on the right, you might recognize somebody from the LCAP group. But on the left are the questions from the nodule grid. And I won't go through them, but you can imagine that each time point you get another column here. And you'd fill all that out. Again, the AI can do that. So this is an example where the AI has filled it out. Everything in yellow is the AI. And we've even given a thumbnail to show you what the AI found, what the measurement is. You can quickly review it. And again, press a button and you've got a report. And the radiologist can go edit that. So what we're doing now is we're working with VA Medical Center in Phoenix. We have Sam McGuire on the line. We'll be hearing from him shortly. We are working, of course, with Mount Sinai. And right now we're testing this. We'll be testing this shortly on lots of cases. And we're going to start to get a sense of, well, how much productivity is improved and what are the opportunities. And part of the reason for this panel is to start to explore what kinds of opportunities what kinds of things can we do now once we integrate AI into this clinical workflow. One of the things I want to point out to you is that we do encourage everybody to use calibration phantoms, right? I showed those earlier. And what do we get when we get those calibration phantoms scanned and passing at a site? The image quality is passing. We get the precision and any biases of the measurement system. So if somebody was measuring diameter, and let's say it's a 6 millimeter lung nodule, and it has a 1 standard deviation of precision of 0.5 millimeter, which is pretty good. That's 0.5 pixel for a large patient. If they had a stable nodule, you would see this green band. So that's, again, 1 standard deviation. You'd see this green band over time, and you'd expect that the measurements would all fall in that green band. But if you had somebody with 180-day doubling time, they would have the red band. Now, one of the questions you might ask is, how much time should I wait before I call the patient back and try to measure whether there's been substantial growth, significant growth? And what I'd argue is that it depends on the width of these bands, right? Which could depend on the scanner, the protocol, the presentation of the lung nodule, lots and lots of things. But we're now at a point where we can both with quantitative imaging algorithms and AI, we can narrow this down and possibly bring the time in or the confidence level up, or a combination of the both. And what we'll be doing is we'll be adding this to this system so that you can watch the nodules changing over time along with their confidence intervals and see see whether or not there's nodules that are of concern, and get a visual representation of it, which is a little more powerful than just, again, a number. which is what everybody's working with right now. So we're planning to add a lot more technical capabilities into the management of lung nodules. Maybe one day we can get to a precision follow-up time. I'm sure Ella can tell us what version of LungRads might provide such a thing down the road. But to me, it's very exciting because I know that some sites might have a neotome alpha, right, with a 0.2 millimeter resolution, and some sites might have a really old scanner with poor resolution, especially out in the periphery, where lung nodules often arise. So it's a very exciting time to bring technology in, bring AI in, and as I said to you before, there are lots of things we have to really think about as AI comes into the workflow. So first thing is that I think it's safe to say that lung nodule CAD, which is what it used to be called, but is now AI, is growing in acceptance and use. I just get that feeling, but I also get the feeling that it's happening maybe in the major academic medical centers. I don't see it happening in the community hospitals. As I mentioned to you before, a shocking failure is the Achilles heel of mission critical AI, which is the space we work in. So we gotta not just pay attention to the statistics, the overall statistics on AI. We have to also look at how often do major failures occur, and what are the consequences of those failures. Also, a common theme for all of these years has been AI that supports radiologists, works in conjunction with radiologists, either to take some cases and declare them not needing a lot of effort or time, or generally helps the radiologist, not tries to replace them, is generally the better approach. Lack of large, high-quality databases remains a major challenge, and I don't believe it's going to stop soon. It's only gotten harder, in my opinion. I used to be able to get data from sites all over the world, and now with the IRBs and the HIPAA requirements and everything else, it's literally, I'm begging just even to get a couple of cases. There's no amount of money that can solve this problem. So that's a whole other area. There are serious ethical concerns regarding training. We want to make sure of diversity and other things. There's lots of stories from the past of the first, I think it was the first EKG analysis algorithms were all built with males. So when females came and they got handled by those systems, they didn't do as well. Because so we want to be really careful about the ethical concerns and making sure we don't do poorly on certain subpopulations. And then the main reason for this panel is around this integration of the AI with the clinical workflow. And everything I've heard so far has been that an AI on its own that doesn't integrate with the clinical workflow is not very useful. Unless you have a good path into that clinical workflow, the AI system really doesn't have much of a chance of impacting things. So that's what we're focused on. I have some questions for the panel. I'll just put them up here. The first, so let me introduce the panel. I should have done that earlier. So what we have Raul San Jose Estepar, who's helping with the moderation of the panel from Brigham and Women's Hospital. We also have Dr. Sam Aguayo from the Phoenix VA Healthcare System, Dr. Ella Kazaruni from Michigan Medicine, Dr. Anil Vachani from Penn Medicine, and Dr. David Yankelevitz from, I think it's a small hospital in New York City, is that right? Oh yeah, Mount Sinai, right. So with that, let me let Dr. Aguayo chime in right now and tell us what you think, and then we'll come back to these questions, okay? We're limiting this to like, what, 5 minutes or so for questions? What? Yeah. Sam, can you hear us?
I can. Can you hear me?
Yes.
I need to share my slides. So thank you for the invite. We all know, preaching to the choir, that better technology and better evidence-based protocols are leading to the best possible outcomes in lung cancer screening. And the challenge that we are dealing with right now is how to make lung cancer screening more efficient, equitable, and accurate. And it all applies to what Rick was just discussing. So what we're trying to do is explore how AI is going to help us to leverage precision screening. The whole process of lung screening and surveillance that I'm oversimplifying in this slide starts with identifying and enrolling the appropriate patients for screening. And I'm going to say a couple of words about how AI can help us do this better. I was not invited to speak about AI in imaging per se. There are many other experts that can speak about that. But I do want to say a couple of words about AI helping us managing the results from quality imaging. And it goes to the theme of incorporating AI in the lung health process. I'm going to use Phoenix VA as an example. In 2020, we had about 104,000 veterans that we serve. This year, we're going to have 120,000 veterans. And we also serve another 28,000 veterans in Northern Arizona and Prescott. And for many, many years, we relied on a push system, expecting our primary care providers to send out smokers for lung screening and surveillance. And it was really not a very successful program. So we moved on in 2018 to a process of precision outreach where we look at medical records first, then contacted patients that appear to meet criteria for shared decision making, and only those patients were sent for imaging for LDCT. And basically, the process of precision outreach is just scanning the medical records that already have a bunch of information to decide who are the patients most likely to benefit and call them. Don't expect for them to be referred. And the program works like this. Basically, we have a Phoenix VA LCAP dashboard that is a list of our veterans that meet current known classified criteria for age, smoking, some comorbidities like COPD. We then look at those veterans that appear eligible and call them and bring them for screening. And when we have image information, we use HI, human intelligence, to now add some of these imaging features to the dashboard, which may put the person at a higher priority for coming back or at a standard priority of coming back in a year. When we started this, most of the chest imaging that we were doing in Phoenix VA were incidentals reports. They were not really organized, about 95%. So we thought precision outreach will be more efficient, equitable, and accurate. Since we implemented this process in 2018, we have enrolled now about 2,000 veterans in our program. We have excluded, which is equally important, over 2,000 subjects that would have been sent to us for screening, but didn't meet criteria. 85% of the people that we talk to enroll in the program, that's the enrollment efficiency. And 71% of them are coming back for their annual CT. That's adherence to the protocol. This is only with one lung cancer screening coordinator. And the reason why I'm mentioning this is because we have now exhausted, we believe, the efficiency of the program. So this year, we're adding 2 additional FTEs for that. AI is what's going to help us to be more efficient. And this is what we are going to do next. The 2 choke points is screening records to decide who are the patients we need to bring in for screening, and then fast fast reading the LVCTs and getting that information again to the dashboard. So for screening the records database, we are adding, with funding from MVP and the Department of Energy, additional unknown risk factors. We're going to use machine learning techniques to learn more about gender, other exposures, and medications, for instance, because we recognize that even in the VA, about 1 of every 5 lung cancers are being diagnosed in non-smokers, and our current guidelines do not permit that we bring them for screening. So with AI and better assessment of the medical records database, we may find those factors that should be included in the guidelines. We are also going to be incorporating genetic risk factors from MVP research, and with the advent of computer-assisted radiology, we will now take those findings like shape, location, function, many of the features that you guys have been talking about in this conference, and decide which of those will help us identify the 7% or so of the veterans who are destined to develop lung cancer in their lifetime, and not put so much effort in screening all of these other smokers or non-smokers that are much less likely to develop lung cancer. So precision screening, eventually, with the advent of AI, will be the most efficient, equitable, and accurate. And the 2 choke points, which is the selection of the patients, identification and enrollment, and then the inclusion of the imaging, are where AI is going to be helping us the most in our processes in Phoenix. I'll be happy to answer any questions at the end of all the other presentations. Thank you, Rick.
Oh, thank you, Sam. That's great. Yeah, so I just want to point out that the VA is one of the best environments in the world for collecting data and doing AI, let's say, development and then validation. So we got to pay attention very carefully to what Sam and his group does over there. So now I'd like us to turn to Dr. Ella Kazaruni from Michigan Medicine. Ella, what are your thoughts?
I'm going to approach it from a slightly different perspective, because in order for AI to be meaningfully used and integrated, this is less about what the tools can do and validating them than it is about creating the buy-in from the parties that are necessary to understand its value and implement them. So I look at this really from the bigger health system structure, because I am certain, even from current experience over the last 10 or 20 years and using tools myself, or seeing the outputs on outside exams that come into our system, and paying close attention to the technology, is I'm convinced there are use cases, and there will be an increased explosion of use cases. But like many things, adaption of anything new is challenging, and AI comes with many of those challenges, whether it's for a single item, nodule detection or growth rate or probability malignancy, or whether it's for the myriad number of findings across the organ systems and disease processes, or whether it's used operationally to improve operations or to do quality assurance. There are an innumerable number of indications that AI can help us with in imaging practices, and for that matter, in pathology with digital pathology practices, starting that explosion as well. Health systems really need to be convinced this is worthwhile for the patient population that they serve. And I think we have done a poor job at telling a clear and convincing story on what it is and what it is not. And that's not surprising, given the relatively early stages we are in the maturation of this type of approach to, I'll just say, imaging and images and radiology practices. We hear everything from you won't need to pay as many radiologists, so you're going to need more radiologists to interpret this mass quantity of data and figure out how to synthesize it and put it into reports. And when you have lack of a clear and convincing story, it's difficult to convince health systems, facilities, financiers, and leaders that this is worth investigating, and it makes it seem like this is not something that is ready for prime time. And if there is a clear and convincing story, on some level, but maybe not on all levels and all organ systems and all diseases, again, to tell that story well. Linking it, for example, to improving your uptake of lung cancer screening, your adherence of lung cancer screening, your quality of lung cancer screening, the cancers you diagnose and the lives you save is a convincing story from beginning to end if you can tell that story well. The second layer that I have continue to have challenges in trying to understand is the infrastructure in which this will live for radiologists and radiology practices to use it. And I consider myself at a fairly advanced health system when it comes to AI and its IT architecture and security and so forth. But it is very challenging, piecemeal, one tool at a time, working with vendor after vendor to try and integrate tools that can pull information out of images. Some information that we used to try and look at by ourselves, and others is information we didn't really even know was there that these tools are able to pull out. But when you have to go through multiple vendors and multiple iterations and upgrades, integrations into complex health systems IT environments, it makes it really challenging. And it almost makes it become, if you're, you have to be not somebody who's faint of heart. This is not plug and play. This is not at the level where you buy or upgrade your PACS system and your PACS system vendor comes to you and says, these are tools I have. These are tools that are seamlessly integrated or plug and play. You choose what you want from this menu across operations, interpretive understanding, and quality assurance, and it will pre-present it to you seamlessly without all the challenges of integration and interoperability, which functionally, again, not for the faint of heart, and many people shy away from just because of that. So you end up having your early adopters, your champions, but we're not getting towards the middle of the bell curve. Radiologists are probably at the end of the day, the easiest of these three to get buy-in for. If it's made easy, caveat, if it's made easy. If updates to a readout about a finding are serially integrated across subsequent exams and modalities. If the output is easy to understand and is non-threatening. When you think about the innumerable number of things that can be measured, reported, and followed over time on imaging exams across organ systems, one could easily get a headache. How do you make it simple and straightforward? How do you get rid of this manual step that still exists between getting the information and getting it into your radiology report? And I've seen it get a little bit smoother where imaging comes off the CT scanner, it gets processed through a set of servers, it comes into the PACS, and some fields can be directly linked into your radiology report, verified by the radiologist, and then end up in the final interpretation, perhaps even with images. But that has not been easy to accomplish. And as many of these outputs as we're running, we're getting pushback from our radiologists about, you know what? I don't want to put the ROI on the L1 vertebral body to measure osteoporosis or osteopenia. It's one more piece of work. In very busy radiology practices, we see the increase in burden across physicians and including specifically radiologists. If it's easily done, if it easily goes from image to report, verification in your own cocoon or cockpit of interpretation, I think radiologists will be tremendously receptive to it. If it is not used as a way to say, we devalue radiologists or we don't need radiologists. So in the right construct, in the ease of doing this, I think radiologists are your biggest supporters. But at this time, it's hard to do that when we haven't gotten to number two, which is PACS, interoperability, ease of use, customization of which of these kinds of tools you want to use. It's really quite an IT nightmare. And this is from somebody who I try all the time with these tools that we've integrated to work with the vendors to get field synced together. It's painstaking work dealing through layers of IT and companies out your own health system to do this. And we need to fix this. And if we can fix number two, it's easier to tell the story to health systems. And I think it'll be easy to get radiologists on board.
Oh, okay. I didn't hear it go to me. So I'm Anil Vachani. I'm a pulmonologist at the University of Pennsylvania. I have no slides. I would only reiterate, much of what's already been said by Sam and Ella. My perspective as a pulmonologist on this is that, we're a customer, we're sort of one step downstream from the radiologist, and so we experience many of the similar issues that have been described, just one step further down the road, which is that in the pulmonologist workflow, when I see a patient, I have the fortune of already having a radiologist report oftentimes in front of me. But usually in an advanced practice, I like to look at the films myself. If there are evolving tools that can help me estimate risk of malignancy, I like to be able to view and manage those tools myself. If there are tools that are going to help me identify patients to screen, or how to have patients follow up for adherence, or how to follow up for other incidental findings, those are all also tools that remain of interest to us, but perhaps have not been the focus of, I think, the AI tools that are in development now, which have largely focused on assessing the image itself. So, it's mostly here to say that we feel many of the same pressure points that the radiologists do. We're looking for tools that are relatively simple, that can be used in the context of our practice, can be done simply. We've also experienced the issues of multiple vendors creating multiple products that have multiple interfaces, that have a fair amount of activation energy in terms of learning how to use them, working through the kinks. And so I think that those are all the challenges that remain to be solved in terms of moving this stuff into practice. I'm a big believer that the validation of this work has to be shown. We have to believe and believe in the evidence that outcomes are improved. But if outcomes are improved and the tools are unusable, physicians will not take this up, particularly physicians who are not all that comfortable with AI already, which includes many of the downstream users like pulmonologists themselves. So happy to looking forward to the rest of the discussion, and happy to answer questions as we go.
Oh, thank you, Anil. Now we'll move on to David Yankelevitz from Mount Sinai.
Thanks, Rick. I have several, comments to make, and maybe even some predictions. I was in a conversation recently with Cheryl Hilton, who runs the Institute for Global Health at NYU. She's the Dean of the School of Global Health. And we were talking about screening and automated detection. And she was saying that in Africa now, countries are now moving towards automated interpretation of pap smears because they just don't have enough pathologists and cytologists, and that's the only way they can do it, which I thought was really interesting. And I suspect, in fact, not only do I suspect, I firmly believe that within the next 5 years, we will have FDA-approved products that will be doing automated readings for lung screening, and that the radiologist will not have to look at X% of them, just like they do with the pap smears. X% of them, pap smears, it's fairly high. I think we'll get to, somewhere around the same range with lung screening also, that certain percentage will not even be needed to be looked at. And I really think within the next 5 years, this is going to happen. So that's my strong belief.
Can we write that down?
Yeah.
We're going to check back on you. 5 years.
You heard it here. And I'm this, AI is coming. It really is. There's just no doubt that this is coming, and it just keeps getting. In the US. In the US, this will be an FDA-approved product within 5 years. That's my strong prediction, and I'm taking bets. But I do want to talk about a few things. This whole idea of catastrophic failure, which is, it's really, it is, as you say, the Achilles heel, and it's not captured in statistics very well. There's no way to really describe this. But that's the problem. And I've seen it. I've looked at studies of AI where, it's picking up 2 millimeter nodules here and there, occasionally it makes a little mistake, but then it misses a hilar mass that is like, oh my God, how did it miss this? And that is the challenge. Without question, that's the challenge. Now it's interesting, and I'll hear Professor Mulshine comment on this. immunotherapy has catastrophic successes. I just coined that phrase, but really they use it differently. You know, immunotherapy, for example, you every once in a while get somebody that does unbelievably well, had advanced disease, it disappears, they don't have side effects. And yet, you know, that's like a one in, you know, however many, you know, a rare event. But those successes have driven that field enormously because for the most part, people are getting a little bit of life gain, but overall, they have massive side effects, et cetera. But it's interesting how they hang on to these unbelievable successes. And Jim, I hope you can comment on that at some point. The other comments that everybody made, I just fully agree with. You know, this idea of integration is really important. You know, looking at one screen and seeing the CAD and then having to then write down the findings in your report or whatnot, that's a real pain and that's a drag. The other aspect is there's a you know, I think the CAD has to be really confident. You know, there is a tendency, no matter what, to use the CAD and not for the radiologist, you know, to rely on it more than perhaps they should at this point, where the CAD finds the nodules and the radiologist barely looks at it. It's a little bit like the radiologist who has a great fellow who's read the scan first and has pointed everything out and filled in, you know, the grid or everything, you know, and then, you know, you go and you look at the scan and you zoom through it without carefully looking at it. You can be sure this happens with CAD. And it's happening with mammography. So the idea of how they use it, people say it should be used as a second read now. It's not. It's really, you know, they talk concurrent read. Concurrent read is basically first read for the CAD because the radiologists don't look so carefully once they have gained a little bit of confidence. So the issue of catastrophic failure really comes up. And so anyway, those are my thoughts on CAD right now.
Okay, great. Now, what I wanted to do before we get into the meatier questions, is I wanted to do a quick survey with the clinicians. Oh, wait, Raul, do you want to say anything before we move on?
I mean, nothing specific. I guess one following up on Dr. Jankeveli has been a long day. David, I think it is that it's a very interesting bet, but where are you putting the AI bar? No, meaning because now, I mean, there is evidence that AI can basically get up to par with the radiologist. The thing is, to your point, I think what we want to is have a better system. And I think that that bar that is still a little unknown is what might delay the deployment of these systems in real clinical time. If you know what I mean. I mean, is your average radiology where the bar is for acceptance or for a clinical implementation, or is indeed going beyond that? That is what we probably want as a community, as a society. And that is, where do you define that threshold? I think to me is going to drive a little bit if you lose or win the bet.
It's all about the claim.
Exactly.
It's all about the claim. That's a deeper discussion, but you know, the majority of scans that we look at are not baseline scans. The majority, overwhelming majority, are repeat scans, and there you're really looking for change. And so you have the benefit of having that initial scan. So that's where the bang for the buck is going to come, in my view, is looking at these scans and saying, hey, here's scan 2, scan 3, scan 4, scan 27, and we're seeing no change over time. I think we'll be able to get a lot of those and say, hey, you know, there's no new nodules. The nodules that are there haven't substantially changed. And we can define, you know, things along those lines very well. And I think we'll be able to carve out areas where we can really confidently make a claim.
So now I'd like to quickly ask each of the clinicians whether you use CAD now, AI now, and whether you know of how many other fellow radiologists do you know that use AI currently? David, why don't you start?
Well, for lung screening,
Yeah.
or for, I mean,
For lung screening.
Yeah, for lung screening, I know
But you're zero? In other words, you're not using it.
We don't use it really routinely. We're about to start testing a couple of systems now. We've just installed them and we're going to start routinely testing a few systems now. And we're going to do retrospective studies and things like that. But going standardly right now, I don't use it.
Okay. Do you know of anybody who does?
Yeah, I do. I know some people. Some of my other radiologists were using it in general. They were using a few of the different systems for nodule detections. And but it was sort of a side-by-side system. It didn't help with entering it into the report, but they found it reasonably useful. They did find it useful, it pointed out, but I also saw that they tended not to look so carefully either.
Oh,
They tended to rely on the system to point out the nodules.
so a little dangerous.
There's a little bit of danger there.
Okay, so let's move on to, somebody was going to say something?
Ella.
Yeah, I was going to say we've had a long nodule detection measurement and characterization tool in place that we've used for about 10 years, and we have seen it iterate and get better over time, and radiologist confidence get better. You know, initially we didn't think the borders were quite right, and we wouldn't have trust in the measurements, and it got better for solid, and then it started to get better for ground glass and part solid. So, you know, that slowly evolved over time. The ability to move the information off the server into the PACS directly into the radiologist report, so you don't have to now go dictate each and every nodule, but you can take the list that's there and customize it the way you want with size, location, slice number, density, volume change, whatever the variables are, you can customize it the way you want, and you can delete a nodule or adjust it if you think it's under over measured. We have that. I think something that David said I think is really important is, how is the radiologist really using it? Are they using it as if it's their first reader or their resident or fellow's first read that they're sitting down with? Are they using it to confirm what they've seen? Are they using it as the starting place? And they're going to still thoughtfully look through the rest of the exam, because just like David has said, you know, I've seen a number of cases where you've got, say, a tumor plastered up against one of the central pulmonary vascular structures and they don't detect it. And those can be catastrophic misses. So if you get too confident with it and now you're not doing your due diligence as a radiologist, you will miss things that may be important. And the systems are not, just like humans are not 100% perfect in their interpretation. I don't think any tool will ever be 100% perfect. It'll get better. It'll get better than some humans, but not others. And I think we just have to be thoughtful about the use cases and how we are using it in our practices, and not just say it's a panacea for this or a panacea, that understand its limitations and how it can be helpful.
So you're using it, and are you using what version of it? And do you know fellow radiologists who are doing so as well?
Our entire practice uses it. We use it on our SPECT CTs and PET CTs. So our nuclear medicine division is using it on their exams. We use it on our cardiovascular exams. So we're using it across our practice, not just in the chest radiology area. And we use it on every CT that basically has lungs except for abdomen CTs.
You know, a lot of other radiologists. Are you seeing widespread adoption, or are you seeing?
I'm not seeing widespread adoption. What I'm seeing is early adopters. I'm seeing academic users, and I'm seeing the early adopters in the private practice community, where for them it's a way of adding value in the practices in their competition circles. But you're always going to have early adopters, and they're going to want to go after technology earlier. They believe in it. They're passionate about it. And whatever the new thing is, they'll be chasing it because that's the nature of their practice or their interests. And then you're going to have the really late adopters who are going to come kicking and screaming, almost needing to have regulatory requirements to have to do something. And then this big bell shape of adoption in the middle.
They'll be forced to do it. Okay, so let's move on to Sam. Sam, are you seeing AI adoption in the VA? Are you seeing it with your colleagues that you know, even outside the VA?
The short answer is yes. There is a few VA facilities that are working with different companies that are testing in a very limited fashion computer assisted reading. I don't know that I will call it AI at this time, because we're in the early stages of teaching the computers what matters and what doesn't matter as much. But validation is going to be the issue. And I wanted to add to the uptake of the AI can be also affected by small non-catastrophic failures if they are too numerous. Dr. Casaroni was speaking about the integration of many different tools. And one of the challenges that we're having in the VA now, that our veterans are eligible for community care, is that when we cannot provide the service in a very timely fashion or at the location that is most convenient for the veteran, they can go and have their imaging done at some other facility. Not only the images that we get may not be of the same quality of protocol that we would have preferred, and we're going to have to work on that. But then could you imagine, like when you are driving to your house and Siri keeps telling you to turn this right, and you know better, and you're trying, to go in a different way? Could you imagine the radiologists and pulmonologists dealing with an AI report, critical report, asking them to look at this nodule that you know for a fact that you have looked at this patient and this nodule many times before, but the report is flashing in front of you, critical report, critical report. If we don't integrate all of this information in the way that Dr. Casaroni was advocating for, it's going to be a lot of hassle before people accept that this is the best way to do things.
Yeah, totally agree.
If I can?
Yeah, quick.
So CAD is not only in CT, by the way, for lung screening. There's a real push to put CAD on chest x-rays for lung screening. And the problem you're bringing up, Sam, is a huge one for the chest x-rays, because the CAD identifies things that the radiologist says, it's not really a nodule. But they're very scared to say, forget about it. Because if they're wrong, and then you have a CAD system that said, hey, it's there, people are very reluctant to say, forget it. Mm-hmm. It's a really challenging area, because if they're wrong, big trouble.
That's right. Go ahead, Ella.
So we've had chest x-ray CAD up longer than we've had CT CAD up. And when we first put it up, the big question is, do you save the CAD output, or do you let the reader use it and let it disappear from your system? And that the latter is where our breast screening program was with their implementation of CAD. And that's what we've gone with chest CAD, because there is this perception of overhead of liability. This is a tool to help you. It's not a tool that is telling you what to do. It is part of your interpretive process. And we don't have clear standards for what you do with CAD outputs, and the documentation of, do you save it? Is the documentation of acceptance and rejection clear? Those are the kinds of things that I think are going to play out, one, in the court of public opinion, also in the court.
Let me just add one more thing. We'll come to Anil. We're right now taking in AI results into this management system I was showing you earlier. And the radiologist can say, forget this nodule. I don't want to follow this anymore. But what we're implementing right now is to say, okay, you told us to forget this, but we're still going to keep an eye on it. Because if it starts growing, let's say 5 years from now, we don't want you to have dismissed it. And the question is, should a system do something like that, or just do what you said, forget it entirely, essentially. I'm not suggesting we could answer that here. I just want to point out these are tricky questions, and I don't think we have answers yet. Anil, are you using AI right now in a general sense? And do you have colleagues outside of your institution that are using it?
We are not widespread using AI yet. We are on the Penn side, we are trying a couple of systems for detection. And on the risk score side, we are about to do a small prospective trial of one of the systems that reports out a nodule risk of malignancy score, but nothing more widespread than that. And on the VA side, we are still just standard radiology reads at this point, though, we have obviously looked at the VA PALS program and are intrigued by some of the AI components that have been described and are considering moving forward in that regard. So yes.
Okay, great. Now I want to give everybody else a chance to ask the panel questions. So looks like Jim has a question.
I want to point out that one of the big opportunities in terms of really helping with the management process is this, the slide you were showing in terms of customizing the time to rebiopsy. So picking out actionable cases, actionable screening cases based upon volume change over time, growth rate, whatever you want to call it, is a big need, because right now we have early adopters. Early adopters tend to be big places with lots of resources, this, that, and the other thing. If we go out into the community and they're picking out suspicious cases and working them up, they're doing PET scans with them, they're potentially doing invasive procedures with people who are not properly, don't do high enough volume to have good outcomes, this, that, and the other thing. It's a real problem. If we had, customizable volume criteria for picking actionable cases, it would really decompress that problem in community settings for sure. And maybe you want to comment on that, because I think that's an early low-hanging fruit for validation, because you've got a more compelling use case than some of these other things.
It's interesting. By the way, we have this other group. We've been holding meetings every month on combined COPD and lung cancer screening protocol. Ella's on it, David's on it, Raul's on it. But one of the things that was brought up was they want to know, one of the most important things that such a protocol needs to do is find the rapidly growing or rapidly changing cases. Those are the ones that the radiologist really needs to pay attention to. And so having AI systems not just detect everything it can find, but also pay particular attention to the things that are the most serious, and bringing that, maybe even they could, pull on an assembly line, you can pull down a cord and say, stop the assembly line. Something really important has happened. Maybe an AI system needs to be able to do that if it's highly reliable. Let's go to questions. You wanted to say something?
Yeah, I don't see any questions in the chat, but I wanna ask the panelists. I think every time we introduce a technology, there is a behavior modification component to that. No, a new modality definitely brings in new opportunities, and then you change the curriculum. You start teaching potentially residents and fellow about this new modality, and they forget the old modality. For example, people complain why nobody can read chest X-rays anymore, for example. So I want to ask the panel, as we talk about integration of AI, what are the implications with respect to teaching? What is going to happen with the trainees? If you have basically an AI system reading nodules for you, then will nobody care, and then you miss the opportunity on getting those, the rare cases, because I feel there is a place for the expert in catching up potentially those rare cases. That is where probably you can say, let's focus resources there, but how then you teach that if there is a component taking over? To me, and what are the implications of this process and how we orchestrate that process? Any thoughts?
I'm just going to jump in and say that we've been dealing with this with structured reporting in our PowerScribe templates for years, where we've got, I would say, a group of old schoolers who think that it's having structured reports tells radiology residents they don't need to learn how to do a report. To which I retort, the standard of care has become structured reporting. So we're teaching them how to practice into the future. And I would say the same is true of artificial intelligence and other applications. If tools to help with nodule detection are going to be part of their practice in the future, we need to make sure they know the pros and the cons. We need to know mostly the cons so that they are careful and thoughtful about finding the problems when they're using AI in their practices. The ones that the AI tools find, those are the easy ones, because now they've been called out for you. But what is AI potentially not missing? What are you not seeing? How are you thoughtfully using it? Don't get over-reliant on it and just stop looking. I think those are the important things we need to teach. And I think this happens with any iteration of technology.
Okay.
I agree with that. I agree with that 100%. I wanted to go back to a term that you used, Rick, of looking for the rapidly growing nodules. And I would say that what we're learning here in Arizona is, I would use the word suspiciously growing nodules as opposed to rapidly. The most dramatic, rapidly increasing nodules we're finding here are inflammatory. and the COVID pandemic accelerated that. So we had a lot of critical reports of rapidly growing problems, and it turns out they are the vast majority inflammatory. So I would rather use the term suspiciously growing nodules.
Yeah, I completely agree. Sorry, I didn't say, it should have features that indicate that this is a real serious issue. Okay, do you want to say something?
Yeah. We're dealing with AI, right? One of the possibilities that you have to mitigate against the challenge with over-reliance on first read and stuff like that is you can keep a profile of readers' performance, and you can have some kind of quarterly or monthly or whatever performance, and you can specifically come back and say, you're making this kind of mistake all the time, we got to do X, Y, or Z. So the adaptive development of quality control of the AI reading process, you should build into it upfront the adaptiveness so that you can keep optimally.
Right now, I think the FDA doesn't let the AI systems adapt to the previous results. But obviously, you know, one size fits all for the entire planet is not the best potentially solution. I also want to point out one more thing. I didn't say it. There was just a recent paper on AI approvals. The last 151, I think there's 151 approvals of AI from the FDA, and the average number of cases used by those approvals was around 400 for CT. So when we talk about diversity and equity, how could you possibly cover the equity subpopulations that you need to with 400 cases, let alone, as Claudia pointed out, the diversity in presentations of lung nodules and diseases. Okay, so as I said, many of us have had the pleasure of having a front row seat to AI over the last 35 years, 40 years. And I have to say, it's a little disappointing. We're still at the point where we're saying, you know, who's using it and when are we going to get there? But on the other hand, I remain as optimistic as ever that this is going to radically improve lung cancer screening and lung cancer care in the future. So I want to thank everybody for joining us. We're going to roll up our sleeves after this and get some more done.
So then will he be right or wrong?
I think David's going to be right.
Okay, good. I keep tabs of that.
And an enlightened moderator.
We owe everybody a beer if we get it wrong.
Okay. I'm writing this down.
All right. Thank you all.